Today we will see in ENT one of the important essay, nasopharyngeal fibroma. Its exact cause is unknown. Tumor is predominantly seen in adolescent males. Site of origin is still a matter of dispute. Earlier it was known to arise from the roof of nasopharynx, the anterior wall of sphenoid bone. Pathology, it is made up of vascular and fibrous tissue. Ratio of two components mostly variably. Though benign, angiofibromas do not have capsule. That's one of the important point. The tumor grows from nasal cavity nasopharynx, pterygopalatine fossa, running beyond posterior wall of maxillary sinus. Then extends in nasal cavity, paranasal sinus, pterygopalatine fossa, infratemporal fossa, cheek, etc. Orbits, it also extends in orbit. Frog face deformity. Cranial cavity, it extends through into anterior cranial fossa, middle cranial fossa. Clinical features: 10 to 20 years, profuse recurrent spontaneous epistaxis, nasal obstruction, then conductive hair loss due to used chin tube obstruction, otitis media, mass in nasopharynx, and other clinical features. Then this is gross image. This is histological section. Dilated vessels surrounded by fibrous stroma. This is lateral rhinotomy operation. Then diagnosis done not through biopsy, because profuse bleeding can be occurred. Investigation: CT scan, and in CT scan there's bulging or anterior bowing of posterior wall of maxillary sinus, which is known as Antel sign or Holman-Miller sign. Then MRI, carotid angiography, shows extent of tumors, and so that angiography is done. Arrangement for blood transfusion, because if successful embolization is done, 2 to 3 units of blood should be needed. Treatment: transplantation sublabial, lateral rhinotomy. This is lateral rhinotomy. Then this one is enlargement of the benign tumor. Then transpalatal approach, endoscopic transmaxillary, which is known as Lee-Fort-1 operation. Infratemporal, wells, intracranial, extracranial, etc. Then transpalatal is used for tumors confined to nasopharynx. It can be extended in Sardana approach. Then we'll see the table. When nose and pharynx, when the extent of the tumor is in nose and pharynx, we can do the transpalatal approach. When nose, nasopharynx, maxillary antrum is involved, lateral rhinotomy, endoscopic or Lee-Fort. Then infratemporal fossa, external lateral rhinotomy can be done. In cheek extension, maxillary swing approach, external lateral rhinotomy. Intracranial, combined intracranial, extracranial approach, etc. Then nasopharyngeal cancer, it's a multifactorial disease mainly due to Epstein Barr virus B, seen in Chinese people. Pathology is squamous cell carcinoma. It is squamous cell carcinoma, and lymphopathology is most common. Lymphoma constitute 10%. Then proliferative, ulcerative, infiltrative stages. Local spread, it spread through. This is spread, and this is the clinical symptoms, clinical features. And through foramen lacerum and ovate, which cause ophthalmic symptoms and facial pain. Parapharyngeal space, it causes triggered muscle trismus and Horner syndrome. Cranial nerve palsies, 9, 10, 11, 12. Then retropharyngeal nodes, neck pain and stiffness. Then cervical nodes, upper jugular, posterior triangle node enlargement. Nose and orbit, nasal obstruction, epistaxis and proptosis. Used teach in troop, serous, otitis media. Distal metastasis, secondaries, lung and bone. Then lymphatic spread, nasopharynx rich in lymphatics, and an early lymphatic spread is seen in cervical lymph nodes. Clinical feature: age, most 5th to 7th decade, 6 male or 3 times more common. Distal metastasis to lung, liver, etc. Hearing loss, nasal obstruction, epistaxis, cranial palsy, headache, earache, neck palsy, Weight loss diagnosis, endoscopy, imaging, CT, MRI. Then main positron emission tomography is in CT abdomen, etc. Biopsy can be taken and local anesthesia. Audiogram can be done. Treatment radiotherapy, chemotherapy, and then there is different staging. Radiotherapy is done for stage 1 and stage 2, and chemotherapy is done for stage 3 and stage 4. In nasopharyngeal fibroma, the other treatments are radiotherapy, but it is primary mode of treatment, but it is risk of development of malignancy at later age. Tumor regression is slowly in a year. Hormonal therapy, mainly the flutamide hormone, androgen blocker used, diethyl stilbestrol is used. Then chemotherapy is done, vincristine, blastin, etc. Then we'll move on to acute and chronic. We'll move on to tonsillitis. Acute and chronic tonsillitis. Acute tonsillitis. Primarily the tonsil consists of surface epithelium, which is continuous with oropharyngeal lining, crypts with a tube-like invagination. The types are acute guttural, guttural pharyngitis, acute follicular tonsillitis, spreads in crypt, acute parenchymatous. It both comes to middle, and acute membranous tonsillitis. Membrane is the exudation cools to form a membrane on the surface of tonsil. Acute follicular tonsillitis with yellow spots. Etiology: hemolytic septicus, then influenza. Symptoms: sore throat, difficulty swallowing, fever, earache, constipation symptoms, simple pharyngitis, headache, general body aches, malaise, constipation, etc. Signs: often death is fetid, smell coming, and tongue is coasted. And there's hyperemia of pillars, hyperemia, blood filled with yellow spot, mainly seen in acute follicular tonsillitis. There may be whitish membrane on the middle surface tonsil, which can be easily wiped away with the swab. Tonsils may be enlarged and congested to so much that they almost meet in the midline. Acute parenchymatous tonsillitis. If they meet in midline, then we'll just say it is acute parenchymatous tonsillitis. Treatment: analgesics, antimicrobial therapy, penicillin, erythromycin, etc. Complication: chronic tonsillitis, peritonsillar abscess, quinsy, parapharyngeal abscess, acute rotation, rheumatic fever, then acute glomerulonephritis, rare disease, subacute bacterial endocarditis with valvular heart disease may be complicated. Differential diagnosis: membranous tonsillitis. It occurs due to pyogenic organisms. An exudative membrane forms over the medial surface of tonsils. Diphtheria: dipth is low and less symptomatous. See, less local discomfort. Onto the blood, and this dirty green color. Urine may show albumin. It can cause the culture may show contact diphtheria. Vincent angina is incidence onset. Usually forms over one tonsil membrane. Vincent angina, one tonsil membrane. Then throat swab will show both organisms typical of disease, namely fusiform bacilli and spirochete, two organisms. Infection mononucleosis, this often occurs in young adults. Both tonsils are very much congested and covered. Lymph nodes are enlarged in posterior triangle of neck with splenomegaly. Blood smear show 50% lymphocytes, of which 10% are atypical. Then Paul Bernal test will show high titer of heterophilic antibody in infection mononucleosis. Then agranulocytosis. It presents with ulcerated necrosis lesions, not only on tonsil but elsewhere in the oropharynx. Patient is severely ill. TLC is less than 2000 cubic millimeter. Leukemia: TLC is greater than 1 lakh cubic millimeter. Aphthous ulcer is very painful. Small, quite large and alarming. It's very painful. Malignant tonsil. Traumatic ulcer. Any injury to oropharynx heals by formation of membrane. Trauma to tonsil area may occur accident when hit with toothbrush, finger, etc. Candle infection. Then diagnosis: history, physical exam, TLC, blood smear, throat swab culture, and bone marrow aspiration, all Bernal test, etc. For Faucial Diptheria, it's an acute specific infection caused by gram-positive diphtheria. Spreads by droplet infection. Incubation 2 to 6 days. Some patients are carriers of the disease. They harbor organism in their throat but have no symptoms. Children are affected more often. Oropharynx is commonly involved. Larynx and nasal cavity may be affected. In the oropharynx, a greyish white membrane forms over the tonsil. grayish white, and spreads to soft palate posterior pharyngeal. It is quite tenacious, causes bleeding when removed. Cervical lymph nodes and particularly jugular digastric become enlarged, tender, sometimes bull neck appearance. Patient is ill, toxemic, but fever seldom rises above the complication. Exotoxin is toxic to heart and nerves. It causes myocarditis, cardiac arrhythmia, acute circulatory failure. Neurologic complication usually appear a few weeks after infection, includes paralysis of soft palate, diaphragm occlusion. Treatment is mainly antitoxin based on sites involved and duration of severity. 22 to 40,000 diphtheria and 80 to 1,20,000 units. Chronic tonsillitis, complication of acute tonsillitis, subclinical infection after 50 years. Chronic infection, sinus, teeth, etc. Types chronic follicular same, cheesy, full of crypts are full of infected cheesy material, chronic parenchymatous, hyperplasia of lymphatic tissue, interfere with speech declaration, respiration, attacks of sleep apnea, long-standing cases develop, feature carpal chronic fibroid, small but infected, history of repeated sore throats, parenchymal tonsil, two tonsils are almost touching each other. A tonsil cyst left in 50 normal. Clinical feature then recurrent addresses, sore throat, acute tonsillitis, chronic irritation, throat with cough, bad taste in mouth, foul breath, halitosis, thick speech, difficulty in swallowing, choking, spell suddenly. When tonsils are large and obstructive in parenchymal tonsils, examination may show tonsil may show varying degree of enlargement. Sometimes they meet in midline. There may be yellowish beads of pus in the medial surface of tonsil. Chronic follicular, in follicular, yellowish beads. Tonsil are small but pressure on the anterior pillar express frank pus or cheesy material fibroid. Fleshing of anterior pillar. Fleshing is dilation of capillaries. Compared to rest of pharyngeal mucosa is important sign. This one is very important. Enlargement of jugular digastric lymph nodes is a sign of chronic and acute tonsillitis. Conservative treatment of infection. Tonsillitis is indicated when tonsil intervene speech regulation, respiration. Complication peritonsil abscess. We'll see in future. Quinsy, parapharyngeal abscess, intratonsil abscess, tonsillar cyst. Focus of infection in rheumatic fever, acute glomerulonephritis, and skin disorders. In tonsillosis calculus, it is stone. It is seen in chronic tonsillitis. Inorganic salts of calcium, magnesium are then deposited, leading to formation of stone. It may enlarge and then ulcerate the tonsil. Tonsillosis are seen often in adults, give rise to local discomfort or foreign body sensation. Treatment is simple removal. Associated sepsis are for deeply set stone. Intratonsillar abscess is accumulation of pus within the substance of tonsil. Usually follows blocking of crypt, opening the acute follicular tonsil. Tonsil appears swollen and marked red. Treatment is administration of antibiotics. Drainage of abscess is required. Tonsil cyst, it is due to blockage of tonsil crypt. Thank you.